Well, good morning, everybody. It's 7:30 on this beautiful and yet bittersweet morning. So it is my absolute honor to introduce our grand round speaker. It's a man I've known for a very long period of time, and I'm so honored to be a colleague. Dr. Michael Hart is currently the professor of pediatrics at Virginia Tech Carilion School of Medicine and the section chief and director of the Pediatric GI Nutrition Clinic at Carilion Clinic. He obtained his bachelor's degree in nutrition at the University of California at Davis and his master's degree in nutritional biochemistry at the University of Nebraska Medical Center in Omaha, where he subsequently received his MD degree. His pediatric internship and residency were completed at UCLA in Los Angeles and pediatric gastroenterology and nutrition fellowship at the University of Nebraska Medical Center. He subsequently joined the medical school faculty at Nebraska, Creighton University, and then Emory University, where I think he and I shared some time before moving to Virginia in 1998. He has been the past member of the AAP Executive Board for the section of GI Nutrition, past editor of the AAP Grand Rounds newsletter, past chairman of the Clinical Practice Committee for North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition. He has been the author of innumerable articles. He has been an avid researcher in the areas of GI nutrition, eosinophilic esophagitis, fatty liver disease in children. He has been an enormous benefit to all of our learners at Carilion, at Emory, and all of the universities where he has been on faculty. He is the ultimate academic pediatrician. He's the one that we all long to be like. I have never seen such enthusiasm from beginning to end of a career. I have never seen such joy at being able to be in a clinic setting with patients or to be in a research lab or to be giving that knowledge to others through venues like this. I also know that he has very little sleep. His sleep patterns are very, very tight. And I know that because I get texts at all times. Most of the time, I'm awake myself, but sometimes I'm not. But it's always with a great idea. One of the few things maybe some of us didn't know was that he was a pro baseball player. And so out of high school, he was actually taken up by the Houston Astros.
That's right.
And played for a couple of years in their farm team. So we're happy that he decided to use that skill set in a different way and he didn't pitch, come catch for us.
Catcher.
That's right, he was a catcher, come catch for us at Carilion. And it is with absolute love and happiness and sadness that I let Dr. Hart have his last grand rounds at Carilion. And please, let's give him a round of applause.
Well, it's truly my pleasure, and the residents will be thankful when I retire that no more 5 a.m. texts to ask if your patients did okay overnight. I try not to. I hope and pray you're not sleeping when I text you guys, but I've learned a lot over the years, and the residents and the nurses are what make life go round in the hospital, like our situation. So use them, as you guys know, because it actually saves our rounds a lot. You talk to the people. I always got to catch them before 7 o'clock, though, before they rotate off. So you got to make sure you talk to the night nurse, not the day nurse. But you don't want to play a telephone game where they're telling you, what the nurse just said to them 5 minutes ago. So anyway, one of the things, it's really been a pleasure and an honor to be here. And many of you know I've done a blog for a decade or more. And most of you have already kind of sent me your notes that you want to sign up. When September 30th come, I lose my Carilion Clinic email address, but I'll still have the mhhart@vt.edu address. And if you're interested in doing that blog, which is sent out as a blind email, not really a blog, that no one else gets your email address, you just send me a note, either to Carilion or Virginia Tech, say sign me up on your blog. What we're talking about today is really important because you guys could be seeing, we're seeing an increased amount of this, and you're going to see a lot more of it. And this is an epidemic in terms of healthcare. And I mean, vaping's getting all the press, but NAFLD and Nash is what you're going to see. And those of you in training, whether you're a student or a resident, you're seeing exponential. If you look at the data, the NAFLD, as I'll show you, has paralleled the pediatric obesity and adult obesity epidemic. So no disclosures today. But what is NAFLD? Well, NAFLD is non-alcoholic fatty liver disease. But basically, in essence, it's fatty infiltration of the liver by biopsy or by imaging greater than 5% of the cells. And it specifically says no significant alcohol intake, no genetic disease that would otherwise cause that, no medications you're taking. So that goes without saying. They want a pure diagnosis, but it's really a big issue. Underneath NAFLD, and you'll see this when you read the literature, you're going to see bland steatosis is just the non-alcoholic fatty liver, if you will, with bland steatosis and just fat deposition. Okay, we have a lot of that. Livers tend to do that, put a lot of triglyceride. That's not as worrisome as this NASH, non-alcoholic steatohepatitis, where you get steatosis with inflammation and you get hepatocellular injury and ballooning. And the bad part about this, as I'll show you, based upon host responses, genetic factors, is it sort of can lead to a lot of bad things, including fibrosis and cirrhosis. And it's ridiculous how much this has increased in the last decade or two. If you look at the clinical features that you're seeing in your office today, and one thing I think everybody knows who's rotated with me, I don't care if you're coming in for constipation, you're going to get a printed growth curve out of my office. It's so easy on Epic now to just pop up and hit the growth curve and see where the BMI is. I know they may end for a sore throat or whatever, but I think we have an obligation as physicians, as private providers, to show that data, because that they may have constipation, but I'm not going to ignore a BMI of 44. I think you have to have a global approach. And this is one of those kind of iceberg phenomena where these kids have it, but because we haven't been cued in to look for it, we're missing a lot of it. So when you see abdominal obesity, increased waist circumference, that's certainly associated. Insulin resistance, prediabetes, type 2 diabetes, you have to have a presumed NAFLD unless you're proven otherwise. The race is interesting. This gets to the genetic issues, because if you look at, I'll show you the data, Hispanic populations are the highest risk. White or less so, and African Americans are the least at risk. And this really gets to the genetic factors that are important in the phenotypic expression of this disease. We know age plays a role, peri and postpubertal. ALT is what I'm going to focus on. One take-home message today will be that ALT, which is a surrogate marker of liver injury, not exclusively liver, but it's, when you get it above 80, plus if you see increased AST and GGT, there's sort of red flags, soft red flags that you need to be thinking about. Dyslipidemia, of course. You'll see a lot of this is syndrome X-like or metabolic syndrome. A lot of crossover, but not, just like I tell patients, not everybody who drinks alcohol gets cirrhosis. Not everybody who's overweight gets NAFLD. Not everybody who smokes gets lung cancer. But clearly there's association, and then there's host response factors, genetic factors, ethnic factors that play a role in the phenotypic expression. So we need to be thinking about that as we see increasingly amounts of Hispanic populations in our clinics. What's the future implication of kids with NASH? Well, NASH-related cirrhosis in the United States alone has increased sixfold over the last decade in adults. So we're talking about, and this now second leading cause for liver transplantation in adults. Right, it's actually, if you look at the last 3 months, it's actually surpassed hepatitis C as the reason for transplantation. You said, what's that? Transplantation in a fat kid? What are you talking about? It's because we're not, once again, we're beginning to realize that just as alcohol is toxic to the liver, excessive fat in the genetically susceptible individual is literally toxic to the liver. And once you put it in that context, and you take the context of, we all know about prediabetes, we all know about type 2 diabetes. Well, NAFLD is basically, we think, an antioxidant injury or oxidative stress injury and an insulin resistant. So the triggering factors in terms of the pharmacology, in terms of the pathophysiology of this disease is very similar to some of the other drug-induced or alcohol-induced liver damage. And like I said, transplantation, as you'll see, even in pediatric populations, is not unusual. It's increasing. It's the most rapidly growing indication related to hepatocellular carcinoma. Hepatocellular carcinoma? Crying out loud, we know that. I thought that was just hepatitis C. NAFLD, NASH, inflammation begets dysplasia. Remember that. I don't care what organ you're talking about, whether you're talking about thyroid or your colon. We know that not all patients who have ulcerative colitis get colon cancer. You can look at the data, you see you get increased risk of colon cancer. But it's clear if you have, just like skin, sun damage, genetic susceptibility, and I know this personally, many of you know, this has been a melanoma and a squamous cell year for me. You're a white-skinned, red-haired kid who has no melanocytes growing up in California in the 50s and 60s without sunscreen. Guess who gets to know the dermatologist? And some of you saw my massive scar that Jim Thompson did an amazing job. Don't you think the left side of my neck looks about 20 years younger than the right side of my neck? So I said, Jim, I want you to make this, call it melanoma, I don't care what, you just make this side look as good as that side. And he's a godsend. If you guys don't know Jim Thompson, those of you who work with craniofacial stuff, the guy is amazing, absolutely amazing. So anyway, it's really increased. So hepatocellular carcinoma for NAFLD, that's like, whoa. Although long-term outcome with children with NASH remains unknown, these trends in adults are worrisome. So we try to extrapolate when we can, but sometimes it's not always that easy because you'll see the data. Pediatric NAFLD is different than adult NAFLD. So everything we do is try to extrapolate adults to pediatrics because of the sheer volume. We know that NAFLD is the most common cause of pediatric liver disease. There are no studies describing the incidence, though. That's a problem. I'm going to show you some data. We have data on obesity and so forth, but the problem is this requires some invasive testing sometimes. What happens in your world, in the reality in your clinics, is you're usually thrown this when the kid has gone to the radiologist for an ultrasound, or you do happen to do a screening lab, and you get a high ALT. Or you get an ultrasound report that says, you know, kind of some heterogeneity to that liver. I think the kid's may have some steatohepatitis, and then as a primary care or provider, you go, no. You know, I mean, so that's what you're going to land in your lap because we don't have prevalence studies. I'm going to leave you, when you're done today, with who you should screen. And it's going to be very similar to what the American Academy's recommended, American Heart Association for cardiac and so forth. We look at the prevalence of NAFLD. It clearly parallels obesity, 2.7-fold increase 1980s to the current era, probably even higher than that because we don't know what the true incidence is of that. The prevalence varies with age, gender, race, ethnicity, and BMI. And that's really important because the Hispanic population is going to be much more higher risk than the African-American population, and because of genetic factors, host factors in terms of the response. So it's important to understand that. We know the increased prevalence of NAFLD in children with certain risk factors, prediabetes, type 2 diabetes, obstructive sleep apnea, and hypopituitarism. Each one of these carries a genetic risk factor independent of BMI. That's important to realize. So those are factors that I think we just assume it's all linked to BMI, not necessarily. If you look at the prevalence in children 2 to 4 years, 0.7%, 15 to 19, 17%. Obese children by ALT elevation, 29 to 38%. So if you happen to be screening these labs, you're going to find these kids today in the clinic, tomorrow in the clinic. Your continuity clinic is, okay, wow, your ALT is 86, now what the hell do I do? You know? Well, we're going to talk about that because you're going to see it. If you look, you will see a lot of this. The obesity epidemic is getting worse, sadly. And you see that 11 to 22, 4-fold increased risk for Hispanic children, 10.2 prevalence rate Asian, 8.6 white, 1.5 African American. So that's a pretty dramatic genetic influence, isn't it? I mean, you think about that, that's a huge difference in terms of that risk factor. So the kids with type 2 diabetes had a 48% prevalence of elevated ALT. So if you see a kid who's got a BMI of 40 in your clinic, which you'll see today, if you don't look for it, you're not going to see it. But inflammation is ongoing, or maybe it's not. We should know, though, because we need to intervene. This is under the surface of the water. This is an iceberg phenomenon because these kids are basically dying before our eyes if they have ongoing inflammation and fibrosis. So this is why we've come up with screening. And just like the Academy of Pediatrics, as you'll see, talks about universal screening of lipids, you know, hit age 11, maybe these risk factors that, you know, maybe I need to at least check an ALT. I don't need an ultrasound. We'll talk about the utility of ultrasound. If you've got a kid who's got obstructive sleep apnea associated with NASH and 2 pediatrics, these are independent, as I mentioned to you, of BMI. So these are separate risk factors. Children with hypopituitarism, increased risk factor, and even cirrhosis, independent of BMI. So that's why it's important to know how many kids do we really have who have obstructive sleep apnea. Dr. Mez could tell you, I mean, I send a lot of patients to him, but you know what? no one, they come to me for a GI issue, but I'm asking them the questions, about the parents listening. They say, well, no, they don't have sleep apnea. They know the word. I said, well, have you ever really listened to their sleep pattern? And it's, Dr. Smith probably tell you, the reality is parents are underdiagnosing it, in terms of the actual obstructive sleep apnea in our pediatric population. So ask the right questions to get the right answers and make the appropriate referrals. So the prevalence issue of pediatric NAFLD parallels the growing obesity epidemic, which I think you all clearly know. That prevalence varies in population screen by race, level of risk, modality, and how you detect it specifically, and it's higher in certain subpopulations. These are worth remembering. The overweight and obese child by BMI. Males more so than females. Ethnicity is important. If you look at the Hispanic population, much higher than Asian, Caucasian, and then African American by far the least, which is really encouraging to know that difference so that today, when you're seeing a patient in the clinic, I need to screen this person, or maybe not. This is a Hispanic population, BMI is 40. Absolutely. Prediabetes or type 2, obstructive sleep apnea, and hypothalamic dysfunction. So in terms of medications, you're going to see this is really a challenge for us because I'm going to show you some data upcoming about recent data, the tonic trial and so forth, and there's a paucity of research being done on medicines to help impact hepatic inflammation from Nash. We learn from our adults, but as I'm going to show you shortly, pediatric and adult NAFLD are almost two separate diseases. The histology is different. In adults, we see that liraglutide, sitagliptin, but not insulin glargine, improve metabolic outcomes in patients with type 2 diabetes, and NAFLD when combined with metformin. This is just released in the last couple of months and published. So this is encouraging. This is encouraging for adults, but we can't necessarily extrapolate for kids, but we're on the cusp of this. So pay attention to this because what we'll see 5 years from now is these studies that are being ramped up for kids will have outcomes, which will be important. In adults with type 2 diabetes and NASH, vitamin E with pioglitazone versus placebo noted that both vitamin E and the pioglitazone group showed reduction in NASH and NAFLD activity score with reduction of risk of fibrosis. Vitamin E alone reduced steatosis but did not affect inflammation and ballooning. Thus, the combination was superior to vitamin E alone and placebo. Because remember, in terms of the pathophysiology of this, oxidative stress and insulin resistance. So it makes sense intuitively that vitamin E, other antioxidants and selenium and things like that haven't been studied, but they probably should be. The reality is it's an oxidative stress process that causes inflammation. And whether we are going to be looking at anti-cytokine therapy, I'll show you some of the data that perhaps we need to be thinking about this like we think about Kawasaki's. I think about IBD. We think about, Dr. Whaley talked about this, the reality, I think we talked about 15 years ago about Kawasaki's. I remember I asked you on the fourth floor over there at community about Remicade and Kawasaki's. We remember that you had that conversation. I said, God, what's happening to TNF alpha and some of these inflammatory responses? These inflammatory responses that cause all this devastation that we see, and the research hadn't been done. But we're starting to learn that anti-inflammatory, directed against the inflammatory process. The only good inflammation is dead inflammation. Let's face it. I don't care whether it's in your colon, your thyroid, your liver, or whatever, and that's really, now we want to sop it up. That's what we do in GI with the anti-TNF drugs, but wouldn't it be better if we could actually prevent it? Take it a step up in terms of the actual inflammatory cascade, and that's what we're learning from the inflammatory process, the vitamin E, perhaps prostaglandins play a role, other cytokines. So I think the cool thing about this is that the next 10 years, you're going to see a whole new class of drug approaches to this. In terms of the mortality in pediatric NAFLD, this is a study looking at 66 kids, mean age of 13.9, and you look at the observed versus expected, and we're talking about significant time since diagnosis. These are 4 events, 2 patients died, 2 ended up in liver transplantation. These are kids, 13-year-old kids, being sent for a liver transplant for fatty liver disease? What are you talking about? It's there, and it's going to be increasing in prevalence. When you see it, and when we do biopsies and actually obtain that, you say, OMG, there's cirrhosis already. We're always stunned when we see some of these kids in our IBD populations who've got primary sclerosing cholangitis, and we've all seen them. They come in, they got IBD, and they got this cross-inflammation, and dang it, their liver doesn't look like they've been drinking alcohol for 60 years, a couple gallons a day of whiskey. It's the actual inflammation from the disease process that is, and that's not necessarily external. In some cases, it could be internal. This looks at increasing mortality in pediatric. Now, 229 adults, biopsy proven, compared to the National Registry. You see increased risk of mortality. Look at the relative risk factors: cardiovascular, hepatocellular carcinoma, relative risk of 6.55. Wow. Infectious and cirrhosis. So we're talking about the big difference in terms of the cases versus controls over time. This is adults, but pediatrics mirrors this very similar. The problem is with kids, it appears that NAFLD is a more aggressive phenotype than it is in adults. Yet I think we in pediatric world lack that awareness that our adult colleagues do. I think they're much more cued into this in terms of looking for it than we are. So if you look at the severely obese adults versus this column, severely obese adolescents, and whether it's Nash or the NAFLD activity score, fibrosis, or mean, look at these values over here. We're talking about dramatic differences with the kids being much worse when we look for it. If you don't look for it, you don't find it. So it's really important to understand that difference. The natural history, we're going to be learning more and more about this. But right now we don't have a lot of data. It's very limited from these studies. We had a great study published by Joel Levine out of Columbia, 11 multi-center study. I'll show you some of the data for this coming up, where they actually had some of the big liver centers looking at this. And we're going to get better and better and better, and it's clearly being recognized by the NIH. But the extrapolation of adult natural history is just insufficient because of the early onset of obesity, increased severity of obesity, in utero exposure to maternal obesity, insulin resistant factors, and the role of hormones play a big role. And we don't know necessarily what's going on. We clearly know the kids are worse off than the adults are, but we don't necessarily have the smoking gun. We kind of have a hunch, but we don't necessarily. So the delineation of clinical outcomes in pediatrics requires long-term follow-up of those kids into adulthood, as you'd expect. Just like we learned in our IBD patients diagnosed at age 5, they said, gosh, you know, when that patient's 25, they're seeing a lot of hepatocellular carcinoma, a lot of adenocarcinoma. We learn from the fact that time plus ongoing inflammation makes a big difference in terms of the phenotypic response and risk factors. So focus on this upper limit for ALT, because right now when you get the results back in EPIC, it gives you normative data. But there's probably different, that's adult normative data for the most part, not pediatric. It's not the children's hospital data. Regional labs use population norms, do not exclude the overweight or obese for other causes of liver disease. So they already skewed it based upon their population norms, because everybody gets thrown into that for norms. Even the abnormals with such a high prevalence rate is going to skew your mean, won't it? It's going to skew your mean and your range is up. So the median upper limit of normal at children's hospitals is 53 with a higher range. So if you look on EPIC, you're going to see it slightly higher. 95th percentile for ALT and healthy weight, metabolically normal, liver disease-free, NHANES adolescent group. Look at that. For boys, 25.8, for girls, 22.1. How many of these kids that are sitting at 50 that, oh, it's normal, are actually we missing potentially in terms of an opportunity to screen these kids, because that normative data has skewed because of all the in there. You throw in the good and the bad you're going to have, and you're going to throw your mean off. So I want to leave you today with that notion that focus on that ALT and your cutoff. Here's your cutoff for the actual healthy kids. You know, 25.8 for boys, 22.1 for girls. That's quite a bit different than 53. And unfortunately, the limitations are it's poorly correlated with histology, but it does seem to correlate with that own individual over time. So that's why it's important to get it. It doesn't tell you, oh, they've got, you know, fibrosis or they've got cirrhosis, because it doesn't correlate with histology. Some studies suggest AST, GGT may be better correlated with fibrosis. I would get certainly all of those in the, you know, get the CMP or hepatic function profile. One thing for the non-pediatricians in the group, family medicine, whatever, it's always important when you order a blood test that includes an ALT, you always need in the pediatric world to throw in a GGT. If you're in the ER setting, you got a kid with belly pain, your CMP does not include a GGT. And your alk-phos is meaningless in a growing child because you're getting a lot of bone turnover. So we say, oh, alk-phos is 300, but they're 13. Oh, what the hell? I mean, that just means they're in puberty. So, and you can make your diagnosis as Gilbert syndrome. You know, sometimes right on the spot, you get your GGT, you get your CMP, normal GGT. Yeah, your bilirubin's 1.5, but the kid is fasting for his blood work. You made your diagnosis as Gilbert's. You don't need any exotic, you know, more testing. You made the diagnosis. If you're called to the emergency room, whatever your specialty, if you're going to order a CMP, order a GGT at the same time, because it's helpful to know that raises a red flag. That helps also. You have come back with an ALT or an AST elevated. Well, that GGT sometimes tells us, oh, this looks like mono. We've had several cases of mono here recently, and I mean bad mono. You know, kids who had one in the ICU that had bilirubin of 14 something, and it was really helpful to differentiate. Oh, look at that gamma. That's clearly an EBV or CMV. That's clearly, you could almost say it was a hepatotropic virus versus a more classic Hep A, B, and C that doesn't give you that GGT bounce. So get it. If you're going to order the blood work, at least throw that in if it's a pediatric population. You know, in any one of us down in the ER, that alk-phos being elevated, oh, you got gallbladder disease. But that's not true for kids, okay? So keep that in mind. And it fluctuates over time, and we know ALT changes with placebo. That really helps us a lot. You can't differentiate between Nash and NAFLD. Big, important differentiation, we can't. ALT doesn't tell you that. Ultrasound. And the most common thing that I get in terms of referrals that are sent to me from pediatricians is abnormal ultrasound was done for whatever reason, belly pain, whatever, and it clearly showed what looked like fatty liver. And now what? Well, send them to GI. So, you know, I'm kind of, then we get them, it's like, now what do we do? So bottom line is the problem is it's not, good news, non-invasive. Bad news, the sensitivity specificity really is tough, especially low levels of steatosis. It's not currently recommended for screening in NASH-BGAN guidelines, and it can't differentiate between Nash and NAFLD. Big, important deal. So, but that's what's going to put them in your office now. That's what's going to be in your report, in your continuity clinics of your patients, going to be abnormal heterogeneity of your ultrasound. And you're going to say, now what do I do? The real thing, I think, in adults, once again, adults are leading this charge, is to some of these newer imaging modalities. Ultrasound-based shear wave and radiofrequency impulse, MRI, elastography, spectroscopy, these are increasing in prevalence. And the concept is of the shear wave, it makes very cool sense if you think about it, because if you are sending sound waves in and you're sending sound waves into a balloon filled with water as opposed to a balloon filled with sand, those sound waves repercussions are going to give you a lot of difference in terms of what comes back. So we know that the shear is important. We can actually make a number to that. Likewise with MRI. You can't be doing MRIs for this stuff. I mean, who wants to throw on $15,000 for a screening, fatty liver? But ultrasound is being done routinely, and that will happen. If you're a resident today, you'll have the opportunity in 5 years to order the NAFLD ultrasound. It's going to get that. I think we're going to see that happen and be in real practice. MRI, because of its cost, availability, probably not useful, but what you're going to see is you're going to see MRIs that are done for other reasons in the hemo clinic, you've got a splenomegaly or whatever. They're going to come back with NAFLD as a diagnosis. So it may be one as you kind of get back into. We know that the adult data, this is where we're going to learn a lot from the adults. It's not the same disease, but it shows the non-invasive liver serologic markers and these fibrosis-4 index, which you can order through the lab, the blood test, transient elastography, can stratify the adult patients from fibrosis to non-fibrosis, and it's really important. They're almost there, so that the generalist can do stratification to say, do I need to send them to GI? Do they need to have a liver biopsy done? The adults are getting close to that. We're not nearly there in pediatrics. The Centaur study basically looks at cytokines. And once again, looking at inflammatory mediators, it's getting close to an adult because they basically could show significant reduction in fibrosis in a population with NASH. So we see they actually showing diagnostic utility and therapeutic utility, which would be really cool. We're going to get there in pediatrics. We're just not there yet. So in terms of screening, who do we screen now? You go off to the clinic this afternoon, you got your continuity clinics, who am I going to screen? Well, it should be considered for all 9 to 11. That's kind of the AAP's universal screening guidelines. Kids over the 95th percentile, how many of those you see? Well, you don't know if you don't print out a growth curve. It does give you the information if you look to the growth curve, but if they're in for an ear recheck, how many times do you guys print the growth curve? Print the growth curve. It's very easy. Go over to, make one of your favorites, click growth, print all. Very simple, very easy. Takes 10 seconds to do, and then you hand it to the parent, And then you say, I know you're just here because you need some more Miralax, but are you worried about your child's weight? Oh, it's just big bones. Oh, yeah, just big bones. How many times, there's a big bone of that mom's 400 pounds. She's got a glandular problem, and the kid's just big boned. If we don't open the discussion, and I don't care how you get them in there. I usually go to Vanity. I tell the kid, how many fifth graders do you see that have BMIs of 40 or whatever? They're bully targets. I'll go to the Vanity for the kid and the medical appeal to the parent. It's got to be a strategy to do that. Whatever works, you got to sensitize them to it, and I always tell them, you got to set realistic goals. Dr. Whaley talked a little bit about this. I said, it's easy for me to tell you tomorrow to become a vegetarian marathon runner. What the likelihood is that going to be to succeed, So you don't set these stupid goals that are, and I don't even use the word diet. I only use the word lifestyle modification, because diet implies there's a race and there's an endpoint there, right? And it's a 4-letter word, and when you go off the diet, you eat the whole box of Krispy Kreme glazed donuts. We all know how that works. And so we have to set realistic goals. So if the parental growth curve, additional risk factors, including central adiposity, insulin resistance, but how often are you guys looking for it? How often are you checking fasting insulin? How are you looking at hemoglobin A1C? I would argue that in the adult population, even if you had surgery in the last year, which I've had 3 of course, and if you had surgery in the last year, you get that done as part of your screening because there's morbidity associated with that. We don't do that in kids. We don't routinely check hemoglobin A1Cs. We don't check fasting insulin. We don't even sometimes check glucoses. Or we get one of 105, we said, he probably ate something. So the reality is I think we need to look for this. How often do we look for dyslipidemia and metabolic X, syndrome X kind of stuff? Well, now we're at least for the screening starting to think about it. But if we can impact this for life, maybe we can help, have fewer cardiac events later on. Sleep apnea, we once again have to ask the right questions. Family history, of course. Earlier screening can be considered in younger kids with risk factors such as severe obesity, family history, or hyperpituitarism. Consider screening of siblings and parents with NAFLD if they have known risk factors. So I think it's important to think about that. You could just look at the eyeball test. You can sort of ballpark say, have you been screened? What do you have? And interestingly, that's where I pick up a lot of sleep apnea is the parents don't admit it in the kid, but they have CPAP. And I think that it's helpful to be aware of that. The best currently available, I wish I had some rocket science to impart upon you in terms of some exotic fibrosis screen for, or do this Prometheus test or whatever. But right now, we're kind of limited to the ALT with sex-specific upper limits of normal at 22 for girls and 26 for boys. You do that today, you're going to say, OMG, I'm really picking up a lot of kids. You get that kid, and even though we have universal screening, even though AAP has made recommendations for universal screening, I was just in Lexington yesterday for clinic. These kids are coming in, and they've not been screened. I don't know where we're failing them, but these kids are 13, 14, 12. They've not been screened. They've not had a lipid panel one time in their life. They've not actually been tested. Even though the recommendations are out there, we're falling short of universal screening. And I'd recommend that we try to do that, in that kids that when they get to be 11, certainly. Increased ALT of 80, I'd say probably over 50, at least warrants clinical concern. Over 80 is more worrisome. Over 50, say, we need to recheck that, not ignore it, not just because it came in the normal range for what EPIC said it should be for adults, but we need to follow that up, maybe in 6 months. That's sufficient to see which direction it's going. Clinically available routine ultrasound is not recommended as a screening test. That having been said, you're going to get a lot of ultrasounds, and you're going to get a lot of abnormals, and they're going to end up in your office because the report says they may have NAFLD. So we incorporate that as part of other workups. You're going to see a lot of that. Follow-up screening is recommended, repeating the ALT every 2 to 3 years if risk factors remain unchanged, but more often if their BMI is going up or other factors. Consider repeating screening sooner if the clinical risk factors increase. So how to make the diagnosis? Well, we're making headway. I think the real endpoint is going to be these serum markers, inflammatory markers, cytokines. The adults are kind of leading the charge in this case. The key is imaging, and I think we're going to get a better place. Right now we do not have validated data in pediatrics for ultrasound shear test, ultrasound fibrosis test. We're getting better, but we're not there yet. Liver biopsy, of course, is what we've had to do in the past years, because that is sort of where we end up. That gives you the definitive diagnosis. But we'd like to have a less invasive technique. We have to validate these, of course, against this. And there are many studies going on right now that are trying to do that, more in adults than kids, obviously. But as I mentioned to you, kids and adults are different beasts where it comes to this thing, the pediatric pattern and adult pattern. This is more of a zone 1 portal inflammation, often with no ballooning. You see all that inflammatory response, all those little dark blue dots in there, or the zone 3 centered injury with a lot more ballooning. You may be able to see that from the back of the room, a lot more ballooning of triglycerides sitting in those cells. Portal and periportal, there's a trichrome stain here. Portal and periportal fibrosis more common in kids as opposed to sinusoidal fibrosis. You see the trichome in the adults. So it's a different disease. The modulators are probably hormones, probably puberty. Other factors play a big role. We don't quite know how to sort that out. Liver biopsy traditionally used to quantify steatosis, and steatosis more than 5% of the hepatocytes is abnormal, and it contributes to this NAFLD activity score, NAS. So clearly, we try to stage that, just like we try to stage other things, prostate cancer or this or that or whatever. Everything is important to stage because we really want to try to see who's the low risk, who's the medium risk, and who's the high risk. That's our goal, obviously. Genetic factors, we play a role. Race, ethnicity plays a role. In imaging studies, investigative ultrasound, MR, right now cost, availability, and validation are the problems we're having with this right now. We're not quite there yet. We'll get there. Those of you in residency training, I think by the time you add 5 years to your current training, you're going to be there. You'll be able to order on the check mark, looking for fatty liver disease on your ultrasound test. You'll be, the question is not whether they've got it or not. The question is, what's the comorbidity? It's not just that you have fatty liver. It's do they have inflammation? Because inflammation then begets fibrosis, and fibrosis begins cirrhosis. And you can't back off from cirrhosis. Once you have cirrhosis, you're done. Fibrosis can be reversed. So that's a big, important differentiation, whether you're talking hepatitis C, hepatitis B, or any other kind of chronic liver disease. When you step from fibrosis to cirrhosis, we think that's the point of no return, that you're down the liver transplant pathway. Liver biopsies, we do them all the time. They're safe, even if the kids are overweight. You sometimes can do interventional radiology. Our interventional radiologists have done it in selected cases where you have segmental livers and things like that, weird anatomy, kind of sinus issues. Our IR people are very good at doing this if you want. We do them all the time routinely. If we do them in the GI lab, we'll do ultrasound, have it there, mark it out really nice, the parameters. And it's really quite safe. They go home the same day. We tend to keep them for 8 hours, and then they make sure they don't bleed out, and then they go home the same day. So bottom line is we do it routinely. The timing of the biopsy, when to biopsy? I don't know. Not established. It's a shared decision. Biopsy helps rule out other liver diseases. You wouldn't want to miss a metabolic liver disease, for example, and whether they're advanced, in terms of their fibrosis and cirrhosis. So I think that's a judgment call. Ultrasound may help us determine whether, we're going to do a biopsy or not. If you start to see some heterogeneity in the liver, you worry, is there some fibrosis? Why is there all this heterogeneity? Maybe there's some, kind of regenerative nodules going on. So that really helps us to differentiate that. The benefits and limitations of each diagnostic approach, the liver biopsy, of course, differentiates. Do you have fatty liver from inflammation, non-alcoholic steatohepatitis? And all of these have different, ICD-10 codes. So they're nicely differentiated in EPIC. You just put it in NAFLD or Nash or whatever. It's important to try to differentiate that. It excludes other liver diseases, and of course, a clinical reference for diagnosis, not only diagnosis but possibly, stratification of treatment. How aggressive do I need to be? And it can also bring in help motivational for the parent. If the parent's having trouble with their nutrition motivation, their obesity management, and so forth, particularly if they've had a problem themselves, say, look, your kid's liver looks like you've been drinking 2 quarts of whiskey every day for the last 20 years. And you can impact that by helping there with weight motivation. So if that's a motivator and you could use that, use it, the bottom line. The liver biopsy is invasive, obviously, requires anesthesia, and samples just a small fraction of the liver. Serum biomarkers, non-invasive and cheap, but right now, it's the sensitivity and specificity issues and the validation. It's true for every biomarker. I don't care whether it's TNF-alpha levels or whatever the disease state is. The biomarkers are going to be a lot of help. The imaging modalities, non-invasive and imaging the entire liver can exclude other conditions, of course, but the cost. An ultrasound is, what, 1/10 of the cost of an MR? So those are important issues, but it's kind of, and the ultrasound, unfortunately, or fortunately, depends upon the operator in a lot of part. You know, the operator really differentiates how good. We know that personally ourselves here in this institution, that it really depends who is doing that ultrasound as terms of some of the information you get sometimes. It's got low sensitivity and specificity. The CT exposes to radiation, so you have to keep that factor in mind. MR, oftentimes for our kids, requires sedation. It's the cutoff. So the cost and just the logistics of getting the test done can be problematic. So obviously, our recommendations are to exclude other liver diseases when evaluating a patient with suspected NAFLD. Very important. Consider biopsy in kids with a risk of Nash. If they're Hispanic, you're going to have a lower threshold to biopsy than if they're African American, for example. Ultrasound not recommended to determine quantification of steatosis due to the poor sensitivity. CT not recommended for quantification due to radiation exposure. It's cost benefit, this whole kind of thing, not just cost, but you know, are you ionizing radiation and so forth. So the goals of treatment, obviously you want it to regress. You have fatty liver, make it go away. Defined as a decrease in steatosis, inflammation, or fibrosis. Resolution, these goals are determined by liver histology. The ALT doesn't really quantify that very well, but each patient is their own control, has been shown to be useful. So following each patient's ALT over time is useful, and actual one-time ALT may not be so useful. Liver histology shows the assessment of change in fibrosis is reasonable as a treatment outcome over long periods of time. Currently requires the liver biopsy for staging. And sometimes that liver biopsy not only used for staging, but also for motivation for the family and reassurance for us. No inflammation, fatty liver, a lot less worrisome than a kid who's got already, you know, you got an 8-year-old kid who's got fibrosis now. You know, you say, well, this kid's on the path to cirrhosis. So it's a big difference for us as well as for patients. Surrogate marker of treatment response decrease of ALT is associated with improvements in NAFLD, but how much of a change is meaningful is still to be determined. So the trend is useful. Their CRP, their SED rate's gone from 40 to 20 to 10. We're reassured in our IBD population. ALT is probably within each patient, probably useful to be that marker over time, so it's helpful in that regard. Ultrasound, not really a good surrogate marker. Wish there was, but it's too insensitive. MR is promising, but once again, the cost, the logistics, and it needs validation, even in adults, not to mention kids. Our treatments, lifestyle, do not underestimate lifestyle. It's at the top for a reason. You know, I don't care whether you're treating reflux. You know, parents want the prescription pad. You know, but if we don't think about lifestyle issues, and you know, in case of reflux, positioning, how much you're feeding your kid, how tight are the diapers, you having them up right after the meals, all these factors play a huge role. But we blow them off many times because they just seem too homeopathic. I don't want to have a prescription. You know. So lifestyle is critically important, probably where I think a lot of this is going to lead. That would be the cure, would be if we bent the whole curve of the pediatric obesity back down like we did, then this would be a non-issue. Dietary supplements, medications, and surgery. This is surgery. So yeah, it's surgery. We're talking about bariatric surgery for kids. Lifestyle modifications to improve diet and increase physical activity are the first line for all kids with NAFLD. Don't underestimate it. Critically important. I think we have to sensitize the child through vanity at the appropriate age, and sensitize the parents through their appealing to their, well, you wouldn't, you know, want your kids to start smoking, would you? You know, I mean, that kind of stuff, whatever it takes, you know, throw out the kitchen sink, because clearly that's going to be our biggest issue. No current medications available for kids. Now, the adults are recommending, once again, oxidative stress, insulin resistance. So this is where many times, you know, we only go with what we have. You know, so we use metformin sometimes, vitamin D, oxidative stress, all that kind of stuff. It's been shown in adults to be useful. You know, and it's not, the data's not out there yet for kids. So right now, there's no currently available medications or supplements to treat NAFLD in kids. Bariatric surgery. So really? Bariatric surgery? Yeah, Dr. Collins is trained. I don't know if she's done her first patient yet. I know she's doing a lot of adults. But this is a big issue in terms of importance, you know, in terms of the kids bending the curve. Just the pediatric population, the Cincinnati, Tom Inge, who's I think out in Colorado, you know, did it for decades basically, and showed that actually similar to the data that we see in adults where sleep apnea, type 2 diabetes, insulin resistance, risk of these factors are magnificent in adults, really dramatic improvement. We're starting to see that in kids. Tom's published good adolescent data, And I think many of us, and Dr. Collins is kind of getting insurance paid for pediatric bariatric surgery for a pediatric patient is still not quite there yet, but it's getting closer. I think the insurance companies realize that bariatric surgery may be our only alternative. We just need to pull the trigger and have good outcome and have good indication, and who do you send, all those kinds of issues. If you got a BMI of over 35 with non-cirrhotic NAFLD and the absence of other, that's the time to do the surgery. You don't wait till they're cirrhotic. You got to do bariatric surgery and a liver transplant at the same time. So you want to stratify who would benefit from the surgery. And there's a lot of psychosocial factors. You all know that liver transplant and alcoholism is a big thing. Well, do you transplant every alcoholic? Of course, that's stupid. They just start drinking as soon as they could give it a liver transplant. You have to stratify. They have to come off of the alcohol. They have to have all these factors to kind of predict they can actually stop consuming alcohol, otherwise they just poison their next liver. So that's what's going to be important over the next 10 years. The dyslipidemia. As per the published guidelines, if you have risk factors, 2 to 8 years old, if the family history of dyslipidemia, 9 to 12 for universal screening. How many of you are doing lipid profiles in a 3-year-old? I mean, Dr. Whitley probably does it if he's got type 2, hypercholesterolemia and the dad or what. I mean, you have to look for those kids where you have isolated risk factors, but this is what we need to look for. You see an ALT in a 5-year-old that's up and so forth. You need to, and the family history of, basically all moms had bariatric surgery and sleep apnea, all those kinds of issues. If we don't really sensitize ourselves to look for it, we're not going to miss it. So get that. If you do that, you want to get your hemoglobin A1C, you want to get your fasting insulin levels to look for. So 9 to 12-year-olds, we're kind of recommendations out there by the American Academy of Pediatrics, but are we really doing this? I would argue no. I mean, based upon the patients I see in the GI clinic, they're not getting this test done. I'm seeing a lot of 14, 12, 15-year-olds who have not had universal screening. And so I think we have a lot to improve. Hypertension, increased risk of hypertension in children with NAFLD and obesity versus obesity alone. So it's a separate risk factor. It's a separate risk factor, in that population. Treatment recommendations as per guideline for overweight children. Obstructive sleep apnea affects 50% of NAFLD. That's a lot of kids have NAFLD. Independent BMI, independent metabolic syndrome. It's associated with Nash and increased fibrosis. So if that doesn't scare you, nothing will. But how many of us are really asking that question to the parents about, you see a kid who's got a BMI in the 98th percentile, are we really asking at time that they're in our continuity clinic about sleep disruption? Sleep, do you listen to your kid? Do you go in there, hear their breathing pattern and so forth? Because if they've got it, you can actually impact that sleep apnea. Increased percentage of time with SAI2, less than 90% relates to hepatic necroinflammation and steatosis and elevated transaminases. So hypoxemia in its own way begets inflammation. We know this to be true, and it puts an oxidative stress on the body, if you will. We know that other unanswered questions, research priorities. What is the natural history? I think that's a real elusive answer in 2019 that you guys will see in the next 5 years and 10 years. We're going to have a better handle on this. The natural history is going to be really important, and it's scary. It is scary. Risk factors that predict progression, non-invasive diagnostics. Can we learn from our adult colleagues? The answer is yes. We're not quite there yet, though, because it's a different disease, but we really want to try to identify those kids that have fibrosis to put them at risk for cirrhosis. And, of course, longitudinal studies of biomarkers and imaging. I would say the biomarker, we're going to have a better handle on those biomarkers in 10 years. That will probably supplant the ALT issue, and that will also supplant who do I need to throw new drug X, the Remicade, if you will, for drug X, for steatohepatitis, for obesity. There'll be a drug like that, but we need to know how to stratify. We don't want to waste our money and just chase those things. So, lastly, board review question. Which of these is right? Number one is changes associated with viral hepatitis are considered to be on the spectrum of NAFLD. Number two, Nash indicates that the process of cirrhosis has begun. Number three, obstructive sleep apnea affects greater than 80% of children with NAFLD. Number four, lifestyle changes are the first approach in liver disease with children with NAFLD. And lastly, children with NAFLD do not have a higher risk of hypertension than other obese kids. Four is correct, yeah. Four is correct. And So I think that it's really important. Obstructive sleep apnea is 50% of kids. So anyway, with that, I just want to thank you all very much. Last weekend at Dallas State Park.
There is, so if we have a kid that goes to the ED and gets appendix ultrasound,
yeah.
and they see something in the liver and they're concerned, should we first work them up with the AST, the GGT, those things that are Pete's office?
Yeah.
And then if the labs are normal, what do we need to do with that imaging?
Great question, and that's what's going to happen. You're going to see an ultrasound in the ER setting that gives you data. The key there is, before you jump to the referral, I would get an ALT, a GGT. You're going to do a comprehensive metabolic panel. Get a comprehensive metabolic panel and a GGT. And because inflammation can beget abnormal ultrasound in and of itself, no, I would not send them to GI yet until I rechecked it in 3 months with that same battery of tests, blood work only, not ultrasound, blood work only, with the CMP and a GGT. If it normalizes, you say, well, I don't know what adenovirus or whatever you heck had there was probably caused, and maybe caused a little bit of ballooning, a little bit of inflammation, and yada yada. But you're all normal now. Get out of my office. If it's abnormal, and of course it's going to be, you're looking at modifying factors. Is the child Hispanic? Is the child African American? And you look at the BMI. Is it 40.2? Is it 36? Those would determine that next tier of, do I send them to GI or not? Hispanic child, BMI 42, you're at much higher risk of having NAFLD than the African American child I just saw. So I think those are great factors, but I would not refer them without having a repeat one-time follow-up, if that makes sense. Dr. Metz.
Question, this is kind of more global. For you over your career, has the normative data for obesity, BMI, changed for the population?
Yeah.
That's important in stratifying.
No, I think Dr. Metz's question is, has the normative data changed for the general population based upon, and the answer is yes. If you look at countries, you look at WHO criteria versus our criteria, you look at even at the NHANES data from the 50s, when it was done back in the 50s, what was considered normal in terms of a lot of other factors, whether it's vitamin A intake and all iron intake, all these, it has changed. It's just like, other inflammatory markers. If you went to the nursery and you did fecal calprotectin or fecal lactoferrin on every baby born in the hospital, they say, well, okay, here's our normative data, and we have 2 standard deviations around that data. Okay, the normal value is 63. If you pooled in all of the kids who have milk protein intolerance in there, you skewed that data. And your point's a great question, because we've done that since 1960. When you look at the prevalence of obesity in adults and kids that have gone through the roof in terms of the prevalence, their normative data is shifting and moving that up. And I think that's very useful, because all too often our normative data is the adult normative data. You know what I'm saying? And how many of our residents that are working in the ER, they get the CMP back and their alk phos is, it's 250, and, oh my God, it's abnormal. Well, they've done the adult normative. We don't, in this institution, we don't even have pediatric normative data. So I think that's a different, Dr. J.J.
Thank you. Wonderful talk. Amazing career. Thank you so much. In your hands, how often does lifestyle change affect lifestyle change affect true change in clinical work?
Yeah, and the question is, in my hands, how much does lifestyle change impact? And that would be true whether it's obesity or Nash or whatever. I think that, I wish I could tell you, I'm probably 20% successful. I wish I could tell you that that's more, but it's probably, the reality is, we had research funding that we did. I mean, Dr. Dudley, who I saw, where are you, Lori? I saw you over here. She just left. I was going to pick on her. We had a grant that we submitted. It was a really comprehensive grant that we did 20 years ago or 15 years ago. It was so awesome. We had funding for the dietitian, for the psychologist. We did an intake. We did a parental assessment of their motivation, the kid assessment of their motivation. The whole idea was to do we had physical therapy funded. We had all this grant funding for this, and we even went out to the home. We sent the dietitian to their home to help the parent with cooking and food purchasing and so forth. And boy, was I naive. The parents don't want us in their home. They wouldn't answer the door. If you try to do too much lifestyle intervention and they're not receptive, no matter, even though our intentions were great and we were giving them thousands and thousands of dollars worth of free health care and yada, yada, and so forth. So I think the key, this is where I think we could really benefit from our psychologist approach. We don't have that luxury, but motivation has to be assessed and readiness has to be assessed. If you're not ready to embark on this journey, now our job is to sensitize them to their health risks associated with not embarking on that journey. And even in the best of hands, I wish I could say that, oh yeah, all the kids walk out of my clinic thin as rails. What do you think, Dr. Oaks?
No, just a comment.
Yeah.
Well, thank you for the great talk. And the optimism is that, you know, the kids just need a good 10-15% to start with as a goal of weight reduction to actually start seeing
I agree, Juan.
the improvement of this ALT, which I usually tell the parents, well, of course, we prefer it if they are thin, but in reality, you know, just a moderate reduction of weight, as it's not even moderate, mild, like 10-15% will make a big difference on this already.
I couldn't.
So and that is absolutely.
Yeah, what Dr. was saying, for those of you on the line, Dr. Rose was saying that even a modest reduction in weight, 10-15%, does translate into beneficial effects. And I would follow up with that and with yours, Dr. J. Joe, about the other thing we're beginning to learn about. This is what our dietitians talk to parents all the time: elimination of simple carbs. Elimination of fructose. Now, we do it for our IBS patients, obviously, but fructose is interesting where it comes to liver disease, because fructose consumption, which of course is in all table sugar and fruit juices, you know, if they do nothing more, we try to eliminate that, stimulating, you know, triglyceride regenesis in the liver, you know, that is not cleaning it out, you know, so there's kind of a double benefit. Now, that's not, you try to go to low-hanging fruit. You know, when somebody comes in with a BMI of 44, I ask them, how much sugar drinks do you consume? And I hope they're going to tell me, I drink about 6 Pepsis a day, and, you know, I'm hoping that's an easy fix. You know, you go to, and of course there's the whole data, you know, the whole data about, oh, the artificial sweeteners are killing us and yada, yada, yada. It's a lesser of two evils situation here, you know. Yeah, the artificial sweeteners probably aren't great and so forth and so on. They're hyper sweet and all this kind of taste bud issue and sensitization. But the reality is you got to eliminate fructose out of the diet. You know, that's a definite liver problem. And simple carbs, definite liver problem, because all those do is just right into fill your glycogen, stuff your triglycerides. And so I think that Dr. O's point is low-hanging fruit, low-hanging fruit. Lifestyle, more activity. Don't mention the word exercise. That's a 4-letter word. But activity, movement, shutting down screen time, not shutting down. You got to limit it. You can't. There's some of these stupid things. Okay, I want you to give up your iPad. Give up my iPad. You know, it's kind of one of those things. What do I do for a babysitter when the kids are in the car? You know, I mean, we all been there, done that. You have to kind of balance that sort of issue. So Dr. O's point is, pick off low-hanging fruit. Small changes are meaningful, and I think you're right, Dr. J. You rechecking in 6 months, because you can give them feedback, not only their BMI, but also with their ALT. Dr. Doherty.
Thank you so much for your talk,
Yep.
Dr. Hart. So clearly one of the take-home messages from your talk is that people of Hispanic background have a higher risk of NAFLD. So in genetics, we've decided that the concept of race is really a social construct, and it's better to think about ancestry, although I think that's very awkward to talk out loud about a person's ancestry. And one of the other things that we're seeing now in the U.S. population is more mixing of populations, and so the teaching in genetics is that you can't necessarily identify a person's ancestry based on the color of their skin. That's just not a good marker. So I think that this talk illustrates a real potential for what's called personalized medicine in genetics. So the concept in preventative medicine for a long time is identify patients before they get sick. And what we would like to do in genetics is genotype patients and figure out what genotype is going to predispose a person to more severe disease or earlier onset disease, and then monitor that patient population more closely.